Dear panelists, speakers, and attendees, on behalf of the Educational Board of the Mega Medical Association and the Egyptian Society of Anesthesiology, I warmly welcome you tonight to a new session from the Mega Medical course. It's a great pleasure and honor for me to moderate this session with Dr. Mahdi. Tonight, and as always, we have very interesting and important topics provided by our eminent speakers. Our topics for tonight are non-invasive ventilation. Our eminent speakers are Dr. Rajesh Mishra from India. So starting now, please allow me to welcome and introduce Dr. Rajesh Chandra Mishra. Dr. Rajesh has got an MBBS, MD Medicine, FNB Critical Care Medicine, European Diploma of Intensive Care Medicine, FCCP, FCCM, FICCM, and FICP. He's a consultant intensivist and internist in Ahmedabad, EPIC Hospital and Kidney Healthcare, Shaibya Comprehensive Care Clinic, president of the ISCCM and a general secretary of the ISCCM. Tonight, he will shed some light on the non-invasive ventilation. Dr. Mishra, please go ahead.
Thank you, Dr. Saad, for this wonderful opportunity, and thank you, Sabat, for this nice introduction. Today night, we are just going to talk about the non-invasive ventilation. The topic itself is very vast, and I'll try to cover as much as possible. If we see in last couple of years, the use of non-invasive ventilation and respiratory failure has increased tremendously. Because initially it was only being used for ventilator failure, that is due to hypercapnia. Now it's being more and more used in acute hypoxic respiratory failure, that is early ARDS, subcases of pneumonia, left heart failure. In hypoxic failure, it achieves its therapeutic target by increasing and expiratory lung volume and oxygenation, where CPAP or PEEP helps, while in ventilatory failure, it offloads the inspiratory muscle, and that is achieved by the CPAP, PEEP plus some support. Before we go to the main content, when we are talking about the basics of NIV, what NIV means that we give positive pressure ventilation with some non-invasive interface, that is invasive interface is taken out. Along with positive pressure ventilation, one more entity has entered in last couple of years. It's called high flow nasal cannula. This also falls in the category of non-invasive ventilation, and particularly in COVID time, more and more patients have received high flow nasal cannula, and we have got excellent result with use of high flow nasal cannula. One thing about the use of non-invasive ventilation, it is timing, site, and ancillary staff. What we have learned in a couple of years, our staff, our nursing staff got more trained, our doctor got more trained, how to appropriately use an IV, how to comfortably fit it, how to talk to patient, how to minimize air leak. And all these have helped us in achieving a better environment to provide non-invasive ventilation. Maybe it is for high flow nasal cannula, or maybe it is for non-invasive positive pressure ventilation. So we know that in couple of 10 years, it has this use has increased. Now, what is high flow nasal cannula? High flow nasal cannula, as you all know, this machine gives us a very high flow oxygen with the help of a blender, and it's a humidified oxygen where we can give 100% oxygen at the rate of up to 60 to 80 liter of flow, and which achieves some kind of positive airway pressure, which helps in improving the airway ventilation, and which helps in improving oxygenation. So wherever there is a hypoxia is a main problem, high flow nasal cannula is helping us more and more in comparison to non-invasive positive pressure ventilation. So high flow nasal cannula, those two things, increases high flow as well as it humidifies the oxygen. High flow improves expiration by alveolar recruitment. It improves inspiration by alveolar ventilation. And this all helps in improving oxygenation and clearing PCO2. While humidified oxygen improves the comfort of the patient. Now about non-invasive ventilation. Non-invasive positive pressure ventilation, when we talk about, traditionally we have a portable single limb non-invasive positive pressure ventilation, and then we have double compartment, double limb positive pressure ventilation. What we have to always remember that when we are using uh, single limb non-invasive positive pressure ventilation, it has got intentional leak built in, and there is a additional leak from side. While in double compartment model, the mask is tightly fit, and it has to open the airway, and then inspiration and expiration is being controlled in circuit. Most important thing is that whenever we use non-invasive positive pressure ventilation, there's an excessive dryness of mucosa. Maybe it is using for acute respiratory failure, maybe it is using for night NIV ventilation for the COPD patient or at-home BiPAP. Humidification remains a big challenge. But we have seen in most of the time that humidification valve is being taken up and patient is given oxygen or NIV support without humidification. And this causes a lot of problems. So we have to always remember that maybe we are using single limb or maybe we are using double limb, humidification is must. This single limb has got a leak for expiration, and whenever we are putting a face mask, we should always remember that we should put a face mask which has got leak. Otherwise, patient will only inspire and patient will not expire, and patient can die because of that. This is what is portable NIV, and very classical heat and humidified HH humidification system is there. Although there is a simple HME can also be put over here or over here. So what we have to remember that when we are using single limb, humidification is must. If we can do active humidification, it is fine. Otherwise, passive humidification is must. Same thing about a double limb. There is a inspiratory limb which can be humidified, or HME can be put here. But no way we should try to give NIV without humidification. Active, when we are using a passive humidification, it does by the heat and moisture exchange principle, and it achieves appropriate humidification. What was the concern with humidification HHME? That by using HHME, you may sometimes get blocked, or it is a dead space, and you may not be able to ventilate the properly. But in this trial, it has clearly shown that HME or HH, that is heat and humidifier or heat and moisture exchange, does not increase dead space, does not increase work of breathing, and it is must to get appropriate physiological response. That's one thing which I want to tell. A small dead space HME does not contribute to the gas impedance in non-invasive ventilation. Now, gadgets. Most important part about the non-invasive ventilation is the interface. This interface can be only nasal in chronic support. This is face mask which is very commonly used, or it can be nasal pillows, or it can be helmet, or it can be complete face which covers both eyes, and it can be only mouth. Different kind of gadget, but most commonly used is the face mask which leaves the eye, which does not cover the eyes, or other is the nasal pillows, and some of the center are using helmet. But we have to remember that whatever kind of mask we are using, it is the leak around the mask which causes all the problem, and with the non-invasive ventilation use. Helmet, it is very tightly fit. It gives access to RT feeding. It gives access to the even oral feeding the patient. But the problem with this is it creates a lot of noise and middle ear problem. Along with that, helmet is less efficient in decreasing inspiratory effort, particularly in COPD patients. So, and it needs intensified training. So the kind of interface which we select is very important. Most of the time we use mask. The important thing about the mask is given if you are not using appropriate size of mask, it will cause skin injury and injury at bridge of the nose, and which can cause even ulcer if mask is being used for a long time. And that's where the concept of mask design physics coming, where the personalized mask, and if it become practical, every individual needs a special kind of mask to avoid this kind of injury and to get seal-proof, leak-proof mask. And that's where our this uh, mask design physics can help us. And that's where we look forward that we can get a mask which can be tightly fit, avoiding any leak, give us the best comfort, and give us the best ventilation can be achieved. And if we are able to achieve that, probably use of an IV will even increase more. Another concern with the non-invasive ventilation is spontaneous ventilation-induced lung injury. We know that whenever somebody breathes spontaneously, there is a tensile stress which is generated at cellular level, at tissue level. With mechanical support, if patient ventilates too much and transthoracic pressure increases and patient becomes tachypneic or alveolar pressure goes up, this can cause compressive strength, and this tissue gets broken, and that's where the problem with the spontaneous. That's where the problem of spontaneous ventilation-induced lung injury. So whenever we are putting somebody on non-invasive ventilation, the concept of transpulmonary pressure should be remembered. And this depends upon the increased transpulmonary pressure, that is the alveolar pressure between alveolar minus pleural pressure. And most of the time, up to 8 to 10 centimeter water of the transalveolar pressure is good to cause appropriate alveolar distension. And if this alveolar distension, if transalveolar pressure goes above 10 or 12, this leads to the alveolar injury, and this alveolar injury further can cause overdistension, air leak, cellular injury, and can cause more ARDS, more alveolar damage, and multi-organ dysfunction and death. So one of the biggest problems which we have seen in a patient where NIV is not being used properly or being used inappropriately, the spontaneous ventilation-induced lung injury, and that causes to multi-organ failure and death. And this is one factor which we have to always remember when we are putting somebody on non-invasive ventilation. So you can land up in the vicious cycle of injury, interstitial edema. You give increased drive, increased main ventilation. You get increased dyspnea, and then increased tonsillar pressure. And over and above, if you give non-invasive ventilation, which is not appropriately tolerated by the patient, then you land up in the spontaneous ventilation-induced lung injury. So what should NIV do? It should reduce the work of breathing, it should raise the respiratory muscle, and should not cause additional harm. How we achieve this? This we achieve by providing appropriate patient ventilator synchrony. Patient ventilator asynchrony is the major problem with NIV, and that we have to avoid. And particularly if you monitor this patient, we can have all kind of asynchrony, right from the double trigger to auto triggering and premature cycle. More and more patients become tachypneic, more and more asynchrony happen, and more work of breathing will happen, and patient will have more lung injury. So we want to give an IV to elevate the lung injury or to take care of work breathing and to reduce the lung injury. But if patient remain tachypneic, patient do not breathe properly, patient do not synchronize with the NIV, then this problem can contribute to more problem. So what is the solution? We need to have a good monitoring whenever we put somebody on an IV. That's one thing which you all remember. So you get a patient, you decide to put on an IV for acute respiratory failure. Cause may be upcoming cause may be due to acute LVR, due to COPD, or maybe due to ARDS, or maybe due to traumatic lung injury, anything you want to. So whenever you give an IV trial, you decide immediately, the first thing you make sure that patient tolerate the interface properly. You monitor the patient for heart rate, oxygen, blood pressure, and ABG. See that patient tolerate and see that patient breathe comfortably. If patient breathe comfortably, you'll find a nice synchronous graph on a ventilator if you are using ICU ventilator. If your trial is success, patient will tolerate, his tachypnea will settle, his tachycardia will settle, his oxygenation will improve, his ABG will improve. This trial you can give up to 30 minutes to 2 hours. In 30 minutes to 2 hours, if your trial of NIV is successful, you continue with NIV. If your trial is not successful, or patient become hypoxic, patient become patient develop altered sensorium, or patient become more tachypneic, then it's failed, and immediately you should go for intubation. Do not wait. If you continue with this NIV itself will cause more lung injury. Another thing, if your patient tolerates, he continues to be on ventilator, then you focus on treating the cause. Once your cause has been taken care, you start reducing the NIV support the way you for ventilator, and then you plan for weaning. So NIV initiation, monitoring, troubleshooting, trial success. If it is success, then plan for weaning. If trial fails, you go for intubation. Many times these patients are anxious, they do not tolerate, and light dose of, particularly we use fentanyl in our setup, and sometimes we also use the dexmedetomidine if patient that helps in tolerating this patient pain and that make this patient comfortable. So in appropriate setting, use of the titrated use of the narcotics or titrated dose of the this medicine help us in continuing with NIV for longer time. Now, clinical application for non-invasive ventilation. You have to choose your patient properly. NIV, even in most grade 1 indication, that is acute exacerbation of COPD or acute LVF, or in any case, whenever you choose your patient, every patient behaves differently. Though you may be giving the best trial, but it's very important when you are using an IV for initial period of time, you monitor this patient and you see that whatever setting you are giving, patient tolerate that, or patient needs more of the NIV support or increased monitoring. If you just put and leave the patient, it may be possible that your patient will worsen or arrest on an IV, and if patient arrest on an IV, you will not get chance to intubate, and most of the time this patient dies because of the hypoxic arrest. So first thing about the HFNC. HFNC in non-hypercapnic hypoxic respiratory failure, we have used in acute LVF, we have used in early yard years, and we have even used in hypoxic respiratory failure due to COVID. And what we have found that in mild to moderate respiratory failure, where oxygenation is the only problem, use of high flow nasal cannula helps us in reducing the intubation, giving more comfort to the patient. Even it avoids going the patient on NIV or ventilator support, and it has even helped us in reducing the secondary complication. So wherever you get a appropriate patient, particularly hypoxic patient who are mild to moderate, who are tachypneic, use of HFNC in a given patient, in a given set of COVID respiratory failure, in a given set of acute LVF, or even in given set of pneumonic respiratory failure, or any hypoxia, particularly non-hypercarbic hypoxia. HFNC is always a good option in given setup. Apart from that, even HFNC is entering to your OT. Even HFNC is being used excessively when there is a crisis, even in ward for mild patient to take care of the. Even in post-op period, it helps us in when you have extubated the patient and you want to buy some time for 4, 6, 8 hours where patient is getting better. It helps us even in post-op period. So even HFNC is being used during intubation, peri-intubation period, where you need to oxygenate the patient properly till you have other gadgets available for oxygenation. So HFNC is putting its place in ICU, in OT, even in emergency, and it is being placed properly. HFNC into airway management, particularly post-extubation support. If you just there may be some airway edema which needs around 12 to 24 hours to settle down. For that period of time, HFNC can be used. Post-operative respiratory failure, mild to moderate respiratory failure. This patient, if you leave after some time, this patient become hypoxic and need to be intubated. To avoid that intubation and to take care of that atelectasis, you can use HFNC in these patients. Contraindication of HFNC if there is a severe injury to face and nose. Choosing non-invasive ventilation, presence of conditions that are typically responsive to an IV, as I told you, acute hypercapnic respiratory failure due to acute exacerbation of COPD has been classically used And most of the patient, around 70 to 80% of the patient respond to NIV support. If this patient do not respond to NIV support, they will tell you in our show. So if there is a worsening of pH, worsening of CO2, worsening of hypoxia, this COPD patient can be intubated, put on ventilator, and after 72 hours, if things get better, ABG gets stabilized, primary physiology gets better, you can extubate and again put them on NIV. The NIV helps in preventing them on going on ventilation. If they are intubated, it helps us extubation and early weaning also. Acute cardiogenic pulmonary edema, classically, if there is not hypercapnic, then it is the CPAP which has been recommended, and CPAP has been used to elevate the LV dysfunction, to help the patient to reduce the preload, to prevent the alveolar collapse, and to offload the left ventricle. So acute LVF, particularly acute and chronic or acute LVF, not all patients of LVF will respond to CPAP. Some of the patient, if this patient has respiratory muscle failure, they may need additional BiPAP also to support the LV function. And in that case, you can use CPAP and BiPAP. Whenever you are putting somebody, the chances of NIV being successful are higher if a patient is young, having low Apache score, is neurologically conscious, there is less of the air leak around mask, patient is not very hypercarbic, not very acidotic, and the moment you put the patient on NIV, if there is an immediate improvement in heart rate, oxygenation, and tachypnea, these are patients are more likely to successful. This one is score which predicts us the about possible high NIV failure. Scoring of heart rate, acidosis, consciousness, oxygenation, and respiratory rate combined together has 25 score, and this score has shown us if the score remains less than 5, chances of NIV being successful even in acute respiratory failure is high. If NIV score in 1 hour, 2 hour, or 12 hour remains higher, the chances of NIV is failure is high. And these are the patients where predicted that they should be intubated early. That's what this trial has shown. And these are the patients they need additional support early. So NIV with the score, with this score of the hacker, it's called HACOR score. One can predict the NIV failure, intubate the patient early, and predict their failure early, and save the patient early. So take home message for this hacker score: if your patient is having hypoxic respiratory failure, you go for hacker scale and do the rapid assessment. If your score is above 5, give initial trial. If it relieves the patient, you can continue. If patient do not improve and his score remains above 5, then possibly these patients should be intubated early to avoid. And those patients who get intubated early, their chances of survival is more than those patients who get intubated late. So always late intubation on NIV, or because it additionally causes lung injury, it takes away your physiological reserve and it causes more complication, and you have less chance of getting successful intubation if you put somebody on long-term NIV. So you have to be very, very careful about it. You should always remember the contraindication for it, non-invasive and absolute contraindication if there is any unconsciousness, arrhythmia, or hypotension. Then always remember the relative contraindication which are related to the condition, and in given condition, NIV can be tried under more strict monitoring, and if fails, then this patient can be extubated. High flow non-invasive plus awake proning has been used extensively in COVID patients with hypoxemic respiratory failure with variable success rate. But as I told you, either you use HFNC, either use NIV, you need to monitor this patient very good. Patient less likely to benefit from the NIV and they need more monitoring. One is the hypoxemic, non-hypercapnic respiratory failure, not due to acute cardiogenic pulmonary edema. If it is cardiogenic pulmonary edema, it will respond. But if it is not that, this means typically all those patients now. But as I told you that in recent time, we have more and more understanding of NIV, better gadgets available. All these patients now coming into relative contraindication, and we are getting more and more successful in bringing out these mild to moderate respiratory failure patients. Acute asthma, it was classically contraindicated to use NIV. More of that was disease where we have used high flow nasal cannula, but now we realize that if this patient starts attaining CO2 due to respiratory muscle failure or due to fatigue, you may use NIV with high flow, increasing flow and decreasing the inspiry time. Post-extubation, post-operative, and chest trauma, these are the patients which are now more and more this category of patients who are alert and conscious and who are cooperative and getting better with the use of NIV. Early extubation followed by immediate non-invasive ventilation in hypoxic failure. As I told you that all those patients of moderate respiratory failure who are borderline, but who are alert and conscious, whose oxygenation improved, disease process improved, to avoid the excessive invasive ventilation and associated complications. Nowadays, a strategy to extubate them early and put them on an IV or even high flow nasal cannula and help them weaning early and give them a spontaneous movement and mobilize them early. It's another strategy which is being used in selective group of patients with appropriate success. Non-invasive ventilation after early extubation, this study has confirmed that it helps. Another thing about the pneumonia. Pneumonia has got variable response, particularly if it's community-acquired pneumonia, where patient has got acute, where patient can clear his cough, is alert and conscious. These are the patients who responds very well on NIV, particularly in mild to moderate category of acute respiratory hypoxemic failure. But patients who are elderly with comorbidity who are not able to clear secretion, their response to the NIV is poor. COVID-19 has variable response to the NIV. It was an early stage, it responded, but it was critical or moderate to severe respiratory failure, they needed intubation. Other viral pneumonia like H1N1 or MERS, their response to NIV was poor. So, non-invasive ventilation in community-acquired pneumonia and severe acute respiratory failure. In this particular study, it was assessed that the patient who are critically ill, their scoring, particularly SOFA or worsening of X-ray is high, they do not respond to NIV. But in selected group of patients, NIV can be successful if they are not very critically ill and their other parameters are stable and they are able to clear the secretion. So pneumonia, initially there was big no, but now in selected patients who are alert, conscious, can clear secretion, their other scoring are not very high, NIV can be tried to them. Immunocompromised patients, initially it was thought that all the patients should be given NIV, but now the data are conflicting. Patients who are critically ill, they need invasive support. Their outcome is also bad because of the disease, but still we should keep a very low threshold. We should try to give an NIV support to these patients, particularly in BiPAP. If it fails, we need to monitor. You intubate them early. Keep a very low threshold of intubation. Do not allow to get them fatigue or do not allow them to get have cardiac arrest. Intubate early, treat the cause early, the chances of survival improves early. ARDS, most of the time, if it is hemodynamically stable, mild to moderate, if hypoxia is only problem, high flow nasal cannula or BiPAP helps. But in moderate to severe disease, you need to intubate them early and do the appropriate ventilation. There are some special conditions, particularly post-extubation respiratory failure, post-operative respiratory failure. The use of both HFNC and IV has increased, and now more and more encouraging data are coming where NIV or HFNC helps in both the condition of post-extubation respiratory failure and post-operative, particularly post-operative respiratory failure, thoracic surgery, abdominal surgery, which has lasted very long. And if it is more than 2 hours, basal lung collapse, atelectasis, and pain contributes to respiratory dysfunction. And most of the time, if you don't take care of these issues, these patients worsens after 12 to 24 hours and needs intubation. So appropriate pain control plus 24-48 hours of the NIV in form of HFNC or BiPAP helps in this patient for early recovery, early mobilization, and avoids intubation. Chest trauma, initially there was thought to intubate, but now chest trauma with good pain control and appropriate use of high flow NIV, more and more patients are getting better with this support. And both HFNC and NIV can be used for pre-oxygenation in patient where airway is difficult, and sometimes if you're planning to do awake intubation, but you do not want you want to reduce the duration of hypoxia, then you continue to give HFNC, or you give NIV support, and then during intubation you remove. So you reduce the period of hypoxemia or apneic period, and that's where it is being used. Bilateral lung transplantation, initially it was thought that this may cause additional injury, dehiscence, and more problem, but now it is being required, understand that more than 80-85% of the lung transplant patients who develop respiratory dysfunction, they respond very well to bi-level support or HFNC of up to 22 to 25 centimeters of the water. And if with this support, this patient get better, their chances of recovery is better than putting them on invasive ventilator support. The role of NIV or HFNC during post-op period is both curative as well as prophylactic. Prophylactic, particularly where the surgery has prolonged, particularly the upper abdominal surgery and thoracic surgery, where the lung collapse is imminent. Using this strategy, keeping the patient awake, keeping them pain-free, make them mobilize early and help them in recovering early. As far as curative is concerned, a post-op respiratory failure where you do not want to intubate the patient, immediately after surgery, you can extubate and put them on BiPAP. But if the patient has additional associated lung injury pre-op or during surgery, it may help in treating it. So NIV, CPAP, or HFNC is being increasingly used in all these post-op surgical conditions. So non-invasive ventilation in chest trauma reduces mortality. It improves the oxygenation, and it clears the CO2. Non-invasive airway pressure therapy for the obesity hypoventilation syndrome, particularly in obesity, this is a role in chronic patient, or if they have acute decompensation, or even at home therapy. We know that all these patients need some kind of CPAP support for to avoid their sleep apnea, and even after that, they continue to have alveolar hypoventilation. They not only need CPAP, but they need additional BiPAP. But 90% of the patients respond to CPAP. And what we have to remember that all these obese patients, because of the excessive increased airway resistance, excessive tissue, they have a high transpulmonary pressure, and that needs to be elevated. They have reduced FRC, and there is excessive airway closure. So keep the airway closure to improve their alveolar ventilation, to cross over the resistance. This patient needs NIV support during sleep. Whenever they have any decompensation, even they come to hospital for the simple admissions, shock, hypertension, any other, but respiratory decompensation will be a part and parcel of disease. And we should have a very low threshold to give an IV in all those patients who become hypoxic in ICU admission. Even the cause may not be the primary respiratory failure. And if there is inadequate alveolar ventilation, which you can find by ABG, by increasing CO2, then you have to combine BiPAP with CPAP. OSA, 90% respond to CPAP. This CPAP should be nowadays, after the sleep study, automatic machine comes, which titrate the pressure level as per the increasing resistance of upper way and the tracheal resistance, and that takes care of the alveolar ventilation. But you need to monitor, you need to see the symptomatic improvement in first fortnight, and if it doesn't improve, you need to monitor the ABG during sleep and after sleep. And if you find that there is inadequate alveolar ventilation, then we have to combine the OSA. So for first 2 to 3 weeks, you have to be very careful when you are dealing with OSA sleep apnea patient. Apart from this, the interface is very important, because this patient needs lifetime and maybe very long-term time single limb BiPAP. So, and most of the time these BiPAPs, the humidification and adequate size mask is missed. This patient needs during sleep nasal mask, and adequate humidification. If you do not humidify the air, then patient will frequently complain of the dryness of mucosa, dryness of mouth, and that will create more problem, and that will lead to the compliance issue. Even nasal pillows are coming, which can be used both as a acute therapy and chronic therapy. I'm coming to my last part about the non-invasive ventilation in a patient who has got neuromuscular dysfunction or chest wall injury, chest wall disease. This patient mostly present with hypoxemia or hypercarbia, and they will have a kind of acute or chronic respiratory failure. NIV in form of BiPAP helps in hospital, and most of these patients, if they have got good airway, upper airway control, good cough reflex, for failing respiratory muscle, particularly respiratory muscular dysfunction in form of muscular dystrophy or phrenic nerve injury, even the diaphragmatic injury, this patient needs some form of active and passive support of the NIV. Muscular dystrophy or muscular injury or myositis, these are the patients who develop respiratory failure gradually. These patients, till they have good cough reflex, until they are able to control the cough reflex, these patients get benefited by the non-invasive support. Once their cough reflex or upper airway muscles get involved, then sometimes this patient needs tracheostomy. So if I have to summarize the use of NIV very quickly, in acute respiratory failure, depending upon severity, ARF severity, mild to moderate. If somebody has got COPD, post-extubation, we are learning and we are using NIV. To avoid intubation, you can use COPD, hypoxemic, cardiac pulmonary edema, and in post-extubation in mild to moderate disease. As far as mild disease or asymptomatic disease is concerned, you need to monitor and do the other medical therapy. You offer only the assistant of NIV when patient has some form of decompensation and that symptom. If patient has got severe disease, definitely NIV helps, but sometimes this patient needs an invasive ventilation. But appropriately NIV in COPD, hypoxemic respiratory failure, being and acute cardiac pulmonary edema helps in alternative to invasive therapy, or may even avoid invasive ventilation. Thank you. Thank you for all your attention, and I hope I have suited around 5 minutes of time. Sorry for that.
Thank you, Dr. Mishra. That was very informative. We've got a question here. So, how to guard against spread of infection when using high flow nasal cannula in COVID patients?
Okay. So initially, when COVID infection was new to us, since it's aerosol generated infection, it was a thought that if you use NIV and high flow nasal cannula, then spread of the aerosol will be more. So, but as we started understanding and intubating this patient, we found that mortality of the invasive ventilation is very high. So to balance that, we have started using 1:1 care, negative pressure room to take full precaution. And believe me, none of our doctor and nurses got infected during for giving care during NIV. So NIV, when you are using high flow nasal cannula with nasal mask, still you can use some form of protective mask to the patient. You use nasal cannula, but you avoid direct contact and maintain a 2 feet distance from the patient. And if you can maintain a negative pressure room, there's nothing like that. But the advantage of using high flow or NIV and the improvement outcome is better than if it used properly in time. And that's why that benefit cannot be avoided. So initially that fear was there that aerosol generation will cause problem, but now we know that if we take appropriate precaution, that can be avoided.
Okay, thank you very much for that. Thank you, Dr. Mishra. So I think there's another question. No, it's the same question. Okay, thank you very much, Dr. Mishra.